Hi. Hi. Just wait a couple of minutes more and then we'll get going.
Russell, we're streaming and public, so you can start at the appropriate time.
Thank you very much, Richard.
Thank you.
Okay, ladies and gentlemen, I make it 1 o'clock on the 3rd of March. Lovely to see members of the public and strategic friends on the call with us. This board meeting is being streamed and will be available for future viewing for anyone who's unable to join us today. An awful lot going on in the NHS at the moment, which we will touch on at different points in our agenda. We've already had a very interesting session this morning covering the work that's going on our strategic narrative, which will come into the public domain over the next few months, but some very common sense things coming through there, and a focus on prioritisation, as well as a really good session on UE's urgent and emergency care performance, which over the last 4 to 6 weeks has really improved. And I do want to reach out and digitally thank all of our frontline teams for the phenomenal efforts and the continued innovation and willingness to be agile and change the way we're doing things to try and improve our performance. Stephen will no doubt touch on a lot of that later, but it is really having an impact on our ambulance handover delays, which are significantly improved. So without further ado, we will get going. And apologies for absence. Joe, do we have any apologies for absence, which I need to note?
None raised with me, Chair.
Thank you very much, Joe. Any new declarations of interest or issues arising? Please raise a digital hand. Can't see any digital hands raised. So the minutes of the Worcestershire Board meeting held on the 10th of December. If there are any points of accuracy, could you please raise a digital hand for me? Again, can't see any digital hands raised, and there was only one matter arising that was noted, which was the update on telephony to be provided to Tony Bramley, and I think that was done. Was it, Tony? Super, thank you very much. We then had the Foundation Group 4 board meeting on the 5th of February, which I know a number of members of the public joined us for. The accuracy of those, which are in draft form at the moment till that next board, if there are any points of accuracy on those, could you raise a digital hand for me, please? Can't see any digital hands raised, and the matters arising, therefore, we will take at that board meeting. So, as I mentioned, an awful lot going on in the NHS at the moment. Glenn, how are you seeing things as our Chief Executive, please?
Thank you, Chairman. So, yeah, there is a lot going on at the moment. It's that time of the year where we're, well, fortunately, as I look out my window, starting to see spring, which means the best thing about spring is the end of the winter for us in the NHS. But also it's the big planning period for us. So I'll touch on 1 or 2 bits and pieces related to that within my report. I'm not going to go through the whole report, but I just wanted to pull out some highlights. And I start off with a real highlight, which is the removal of improvement notices. So these undertakings are set out by NHS England, and they've been around with us for a little while. They're regulatory improvement notices, and we've had 4 of them up until very recently. but 3 of them have now been removed based on the performance of the organisation. So improvements around quality, improvements around the way we manage elective care, and improvements around our cancer performance, all of which come from both either performance indicators or the way CQC have assessed us on quality. So really great to see that. We're left with 1 improvement notice, and that relates to urgent and emergency care. And as you just mentioned, Chairman, we've been seeing some marked improvements in those indicators recently. So I'd hope that quite soon we could be in a position where the organisation has no regulatory notices. And those improvements we've been putting in place around urgent emergency care, we've been running through a whole range of changes, and we knew they'd take a little bit of time to bed in. And it's really good to see that now, actually, when you look at the performance of ambulance handover delays across the Midlands, we're in the better half of the league table, and long may that continue. So the full regulatory notices are included in Appendix A of my report. I then turn to the planning for the NHS in terms of the 10-year plan. A lot of work going on that. What we're trying to ensure locally is that, firstly, that is reflected in our local strategic plans, which we spent some time talking through this morning, but then also checking in with what are called the big moves in the strategy for the rest of the foundation group. And what we can see so far is a really good alignment between what we're doing locally and what seems to be emerging from the national long-term plan. And we look forward to seeing that in more detail. We expect to see that in early May. The annual planning guidance, much later than, and it's often later than planned, but it was later than it's ever been this year. So that was published at the end of January, and we've been working through that. And I pull out from that 1 or 2 bullets in my report about some of the national standards and targets. I think one thing about this year's planning guidance is that it's been thinned out quite a bit compared to previous years. But there's a real focus on 3 main deliverables. One is managing the money across the NHS, which is a big challenge at the moment. The second is continuing the elective recovery of the NHS, and we're certainly locally doing well on that. And then finally, keeping urgent care safe, hence the reference to ambulance handover delays. So there's a whole set of new standards. I think probably the most important thing is we're moving away from looking at elective waiting times as a maximum wait into looking again at the referral to treatment time average for our patients. And all trusts across the NHS are expected to make a 5% improvement on that. And probably the thing that is going to be the biggest challenge as part of that plan is that the elective recovery funding up until now has been there for us to earn for whatever amount of activity we could do as an organisation. Within the plan for the coming financial year, it is capped at system level. And my concern about that is that that could hold us back from using the increased capacity we've created, both through the hub at the Alex, but also through improved productivity. So we're trying to ensure that we can continue to go full throttle on reducing waiting times for our patients. So hopefully that will be resolved as we try to negotiate our way into a contract for next year. I then referenced the urgent and emergency care plan, which will be published soon. No particularly new elements of that to emphasise, although there's a slightly more nuanced focus on whole pathways of care, including the out-of-hospital pathways, the admission avoidance, and out-of-hospital provision generally. And the link into neighbourhoods, which is part of the link into the long-term plan also. I then referenced the productivity tool, not as good as it could be, actually, is my view on that one, but we will use it, and we use all parts of what's called the model hospital productivity data. One thing that I think we just need to make sure we don't get wrong is the National Productivity Tool talks about reducing temporary labour. And reducing agency costs is absolutely something that we're all over as an organisation, and that's helped to contribute to our improved financial position. But our bank staff are our flexible workforce, so I think we just need to make sure we don't try and shrink the usage of bank staff inappropriately, and that's currently what that kind of national plan indicates that we should be doing. Elective recovery plan refresh. Big element of this is how we work with primary care. So trying to ensure that not only do we treat all the patients on our waiting list and reduce waiting times, we need to make sure that only the most appropriate patients are actually joining our waiting list. So there's something called advice and guidance to primary care, which is a big factor in this updated plan, which is advising primary care how to manage those patients without necessarily having to refer them into secondary care. And that national plan also has a big element of use of digital around patient choice and around being able to book your appointments and alter the dates of those locally. I'll try and be quick with two more things. National Staff Survey. So I refer to in my document that it might be published any day now. We now know that it will be published on the 13th of March. I'm really looking forward to the publication of that. It's embargoed, so I'm not allowed to talk about the details of it other than to smile as I reflect on the improvements that you will see when that comes out. And then in more from our great teams, reference to a couple of CQC inspections, both the children's team at Kidderminster and the stroke team at Worcester, and some really positive feedback from the CQC. And then finally, we have added a staff wellbeing and relaxation room at Worcester. I must find out where that one is. And the Alex and Kidderminster already have those. And again, this is one of the factors that when you look at our staff survey, hopefully you'll see that we're certainly improving the wellbeing and morale of our workforce, which is a really important element of what we're about. That's all I wanted to go through, although I appreciate I've gone through quite a lot there.
No, really helpful, Glenn. And but what we would say in terms of staff wellbeing, we're still very conscious about car parking being a very practical issue for staff, both when they start the shift and when they end their shifts. Any questions or perspectives to Glenn? What's worrying you most, Glenn, at the moment?
Well, obviously, over the last week, there's been a change to the leadership of the NHS, and the new chief executive of the NHS they've announced, Jim Mackey, will be excellent. But one of the reasons why he will be very busy is because we've got to manage the finances. So obviously, we can't expect any additional funding from the government, particularly some of the other departments needing more resources. So we really do need to focus on a financial reset. So that's something that we'll be doing locally, but also hopefully trying to influence that nationally.
Absolutely. And I think the need to be very clear about our focus, as we've talked in the past, about bringing life safely into the world, allowing life to leave the world with dignity, and providing excellent urgent and emergency care in times of crisis are absolutely at the forefront of our mind for our citizens. And Colin's asked a question, but I'll ask it for him. Will the changes to the Better Care funding process impact on us, Glenn?
Yeah, I mean, what the national changes to that are is to move away from, is to make more local choices and create more local flexibility around the use of Better Care Fund. It signals potentially an opportunity, which I think we should take, to integrate the resources more between health and care. So it's a positive move forward. Obviously, it's within, they haven't announced any additional funding, but they have announced that kind of local flexibility and more of a focus on outputs rather than looking at the inputs that we have locally. So it's a positive move. And as I say, I think in the long-term plan, we might see more pooling of resources between health and care.
And just to add to that, Glenn, if you don't mind, I mean, I certainly am very worried about the impact of the national insurance changes on our social care providers. We're just 4 weeks away now, effectively, from the impact of those. And I do greatly worry that we will end up losing capacity in social care. And a King's Fund report, I think, came out on Friday, echoing that anxiety that we need to be extremely aware, given our medically fit for discharge challenges we face already, that we don't see the level of social care provision and capacity reduce, which I fear is what is going to happen. Okay, so without further ado, Stephen, over to you for the integrated performance report. How are you feeling about things?
Yeah, so I'll just pick up on some of those things, just a brief highlight. And you mentioned the discussion we had at the board workshop around UEC, which I think without doubt was the difficult thing that the trust's been grappling with for probably from November, December into the first week of January. But then as we would describe, winter was a game of two halves, and then we were 3-0 down at half time and suddenly started pulling it round, I think. But there's been some quite dramatic improvements, and we're starting to see those come through. Notwithstanding, you'll still see the feed through into quality, the workforce issues around stress and anxiety, that whole UEC piece plays through. And obviously it was our biggest risk to our financial performance that we've been managing as well. In particular, what's been really pleasing to see that doesn't quite come through the report, but is around our discharge profile starting to change quite dramatically in terms of the number of days that we're hitting over 100 discharges across both sites, and also the weekend performance. And alongside that, the number of patients that are discharged before midday, which is kind of a good proxy for flows starting to work. That said, we've still got a lot of work to do on our long length of stay, and particularly with our system partners around length of stay in community hospitals and the overall number of patients that are medically fit that could leave the hospital if services or provision was out there for us. So there's still a lot to go at, and that directly leads into that planning discussion that Glenn was talking about, because that's a lot of our cost base that we need to radically redress, really, for us to get a financial plan. There's a lot of positive as well in the report, and I think, again, I would just draw that to when we can manage urgent care and those pressures, kind of everybody's heads can lift, you get a chance to breathe, you can get a chance to do the work on all the other things, so you start to kind of really motor on some of those other indicators, and particularly around patient experience and some of the friends and family tests. There's some really good numbers coming through there in terms of percentages completing it. So again, some signs, but as ever, we have to be really, really vigilant, do a lot of hard work around our elective and cancer performance. And in particular, that just to draw it in, if you can see the number of patients that we've got, the overall waiting list and the reductions that we've seen in that from the peaks of June 2024, it's just making sure that we can keep that productivity going against that planning backdrop that Glenn said. But there's some really hard work and good movement going on in there. So that's just my quick summary. Happy to take questions or hand over to various section owners.
That's great. Thank you, Stephen. Questions or perspectives to Stephen, or shall we dive into the detail? Okay, so we have apologies from Chris Douglas on operational performance. So Tracy, are you going to lead us by the hand?
That's on me, yeah. So following the peaks in demands from October to December, demand in January returned to quite similar levels experienced from January 2024. So as Stephen's already mentioned, whilst January started in a very difficult position, by the end of January and continuing through to February, we are seeing some improvements, particularly with our discharge profile, which is starting to shift and moving towards increased weekend discharges. And that's significantly improving our start of the week in terms of ambulance offload performance and delays to patients waiting in ED. Unfortunately, we are continuing to provide care in the corridor in both our ED departments and continuing to use temporary escalation spaces or boarding spaces on wards on the Worcestershire Royal site in order to support flow and facilitate offloads of patients from ambulances. But we are seeing an improvement in the number of patients that are being handed over within 45 minutes from an ambulance. And at the end of December, I think we were averaging about over 2 hours compared to an average in mid-February of about under 30 minutes. So that's a really significant improvement and is very much as a result of some of those initiatives coming online in January. So as a result of the UEC performance, particularly in Q3, we have been moved to Tier 1 support, and national and regional NHSE colleagues visited the site, Worcestershire Royal site, on Friday to review our current approach, but also to check our progress with the recent improvements that have been seen. So moving on to cancer performance, 28-day fast diagnosis. So we had over 3,000 or nearly 3,000 GP referrals in January, which is the highest we've ever had on record, particularly in skin and prostate cancers. But we are maintaining our position around faster diagnosis for 28 days. A couple of areas to note is around our confirmed diagnosis patients. So we've been notifying 68% of those within 28 days. So whilst that's not the 77% standard, it's just worth noting the improvement from March last year, where we only had 41% of those patients notified within 28 days. So that's really good progress for the teams and the improvements that they're making to the pathways, but there is still some more work to do on that. That will hopefully help for building on that improvement will help us to make sure that we can achieve treating patients within our 62 days of their referral. So 62 day and 31 day are the areas that we really need to focus from a cancer point of view. So for 31 days, the main challenges are around patients who require access to surgical treatment. Those patients that have a decision for chemotherapy and radiotherapy generally do receive their treatment within 31 days. But for some patients waiting for surgery, they're experiencing delays more than we'd like them to. So we've got a bit more work to do in terms of those surgical specialties, because that's impacting on our 62-day performance. And breast surgery in particular has had an impact of 62 days, but there is work underway to develop a bit more of a sustainable solution to deliver their standard. And that includes increasing their access to our theatres. And there's been a recent appointment to a consultant post within that service. In terms of elective care, so the main things to note, let's have a look, not repeating what Stephen's already picked up, but over 1,000 patients are at 52 weeks. We've had 39 patients waiting over 65 weeks, 3 patients over 78 weeks, and unfortunately 1 patient over 104 weeks. Just in terms of that 1 patient, it was a bit disappointing, but it was discovered at the end of January that there was an issue with an administration error, but that patient's now been actively treated with the specialty team. Having said all that, there has been a 10% reduction in our overall waiting list, and that's been a month-on-month reduction for a period of nearly 2 years now, so that's really positive. We don't have a route to zero yet for 65-week patients. We are, as I said, got 39 at the moment. I'm probably looking at around sort of low 30s for February, but just in terms of the national context for next year's 25-26 ambitions, where we're not to have any more than 1% of our patients waiting more than 52 weeks, our current position sits at 1.9%, which is a reasonable start going into next financial year. Thank you.
Thank you, Tracy. Really comprehensive update and lots of positives in there, although we do recognise as a board, if you're waiting for in our urgent and emergency care or being boarded, it's not the greatest of experiences, so we apologise for that. But as I said in my introduction, the frontline team's doing some fantastic work. Tracy, you mentioned the improvement on our ambulance handovers, but just for members of the public who may not be familiar, Sarah, could you just brief us on the way the so-called ambulance pit stop system is working? Because over the last few weeks, we do think that's been a very helpful innovation to help improve performance.
Thank you, Russell. So we implemented the pit stop model on the 13th of January and based on the Worcester site. So the pit stop is run by a team of nurse consultants and advanced care practitioners and operate 7 days a week, 10 in the morning till 6 at night. So ambulances who are non-emergency ambulances, so non-alert ambulances, will stop at pit stop. And the practitioner will go on the back of the ambulance and have a chat with the patient and any family members who are with them and with the paramedic to check whether ED is the most appropriate service for the patient at that time. And if it's deemed that the patient will be better receiving treatment in one of our same-day emergency care centres, which is for cardiology, surgery or medicine, or to go directly to our surgical assessment unit, or back out to see their GP or be cared for at home by the urgent treatment team. So it's going really, really well. And we've now just agreed that we will make that team substantive. So we're just out of active recruitment. And how this is impacted on the safety of handovers and the reduction in delays is that it prevents ambulances queuing outside of the ED department early evening, which was what did used to contribute going into the night with large numbers of ambulances. And at the moment, the team are avoiding between 40 and 50% of all ambulances who are assessed. So those patients no longer go to ED, but into other alternative services. Thanks, Russell.
Great summary. Thank you, Sarah, and thank you to the team who came up with that innovation. Questions and perspectives to Tracy on the operational performance, Glenn?
So Sarah, just on that point, if I could come back to Sarah on that, Russell, if that's okay. The obviously one of the things I was hoping from this is that team would help to alert the ambulance crews to some of the other pathways so that they didn't necessarily need to be pit stop. They could go straight to same day emergency care. So do you think in the long run we will need this team, or do you think in the long run behaviour will change?
So the first question the practitioners do ask is whether the crews have actually used call before convey. So we do ask that question and encourage. At the moment, 50% of all patients who have used, the paramedics have used call before convey, that because they're doing a face-to-face assessment, 50% of those call before convey decisions, which was to transport to ED, are actually being turned around, and the dispatch destination is actually either back out into community or into one of our same day assessment centres. I think that demonstrates just that face-to-face component, or a patient may have actually had some fluids in the ambulance, their observations may have stabilised, which makes it they don't need ED, they can actually go into a same-day treatment centre.
Okay, thank you, Sarah. And Simon?
Thanks, Sarah. So you say 40 to 50% of those that go into the pit stop don't go to ED. So how many of the ambulances come onto our site does that actually equate to? I mean, are we getting, is it about 50% of the ambulances that come onto the site will be pit stopped? And just get a sense of overall numbers. And then if you might not know this, but I'd be interested to know how many are actually turned around and sent back to the community.
I know both of those. I can answer both
Thank
of those,
you.
Simon. So basically, the exclusion criteria are those patients who are red alerts, who are excluded from pit stop, women and children, and at the moment suspected fractured neck of femurs. So at the moment, 30% of all ambulances that attend Trust site on the Worcester site actually come through pit stop, and of those, between 40 and 50% are diverted away from the ED. As we work on our frailty pathways and we're looking at a fractured neck of femur assessment unit at kind of the front door area, more of those patients will actually stop at pit stop and be diverted. So there's real potential to grow the model. And we are transferring back out to the community at the moment, about 3% of directly back out. And we're just working with the primary care networks now for the single point of access to have direct admission into the same day emergency appointment slots, which is the winter initiative, because then we could actually divert more patients back out into local community.
Yeah. Lots of reasons to keep pushing. Well done, Sarah. Well done, Tracy. Now, if there are no other questions or perspectives, we'll move on to quality and safety. And it's back with you, Sarah and Jules.
Okay, so shall I go first, Jules? Can't see on my screen. As we've already discussed, we did throughout December and January, because of the extreme pressure at the front door, increase again the number of boarding spaces that we did have on our wards at Worcester, and that was to reduce the risk of overcrowding in our ED department and to try and prevent those long waits outside for ambulances. Now, what that means is that we've got overcrowded areas and overcrowded wards. So that has had some impact on the care delivered to patients throughout January. So we have had an increase in falls. However, I'm pleased to say that no patient reached serious harm as a result of those falls, and the increase in falls were predominantly in our urgent and emergency care areas. And we've also seen an increase in hospital-acquired pressure ulcers, but not to the same degree of the same time last year. And from our harm reviews, what we know it is from long waits, either at home or on our ambulances, or waiting to be admitted to our beds. And we are already seeing a reduction in those numbers throughout February as our waiting times have improved. We are still continuing to be challenged in our complaint response times, and this still remains with just a single division, although we are seeing improvements in this regard. So I am expecting improvements over the next few months. And I will stop there and hand over to Jules.
Thank you, Sarah. Thank you, Chair. From the CMO kind of part of the portfolio, we're aware of there's the two big ticket items that we're continuing to work on, which are our sepsis screening, which board will be aware has been a challenge for some time now since the introduction of the electronic patient record and the transfer from paper to electronic data collection. We've had another very useful meeting just today, actually, with some of our clinical leads, linking up with our digital leads to really try and understand why we are unable to move that forward and to get some plans in place to really use our digital functions more effectively to help solve that problem. So there is ongoing work in that area. Our time to theatre performance for our patients who have suffered a fractured neck of femur still remains really variable and is quite dependent on theatre availability and access to appropriate inpatient beds. So again, we've seen an impact of the increased activity over the kind of December, January period. It was impacted on that patient group also. But again, there's some good work going on in that space about timely transfer out to community hospitals being led by Sarah's team to try and create some flow in that area, and we're also very pleased to have just appointed a new clinical director for orthopedics who is very cited and keen in this area, so I'm optimistic that that will pay dividends as well over the next month or so. Thank you, Chair.
Fantastic, Jules. Good progress. Questions or perspectives to either Sarah or Jules? Karen? Oh, sorry.
Thank you, Chair.
Sorry, Tony. Karen, no?
Yep. Okay. Thank you, Chair. I can see Sarah smiling. She knows I'm going to ask about complaints, and I understand the work that's been going on, and we have seen some improvements in previous months. But from what you're saying and from what the report's showing us, that doesn't seem to be sustaining, particularly in surgery. So I guess two questions really. A, does that resonate with you? Have I read that correctly? And I guess I'm looking for some assurance that we've got the right focus and your view, and have we got the right resource model in place to address it?
Yeah, thanks, Karen. And I do share the concern, and it's the volume of complaints that surgery, the division are struggling to keep up with the volume coming in and those staying in date, and then obviously dealing with that backlog. However, the team have cleared their backlog at the end of February, as they set out to, and now the corporate team and one of my deputy chief nurses is supporting them to make sure that another backlog doesn't get generated. We've looked and put additional support into the division. So I think it is now just about, with the decks being clear of out-of-date complaints, that they can now start moving forward. What I didn't say is that the new complaints manager is now started in the trust, has hit the ground running and is reviewing our current complaints policy, because it is quite cumbersome. So we're actually going to be simplifying the processes that the divisions need to go through in order to be able to respond to the complaint, and move more to having more meetings with the complainant to discuss the issues, followed up with a very brief letter summarising the outcome, which is very different to how we've done things before.
Thank you.
Thank you. And keeping things going, Tony?
Yeah, thanks, Russell. Jules, I want to come back to the sepsis 6 reporting recording challenge, please, because I've asked questions about this before. We seem to have got a bit stuck, don't we? It's clearly been a long process for us. But what you're saying, do you think we can be optimistic now about a resolution being in sight for that reporting getting on track as it should be? Thanks.
Thank you, Tony. Obviously, we share the concerns that the board have got around this area, because we're unable to be clear about, our sepsis screening compliance in the current situation. We are assured that our overall mortality rates from sepsis remain as expected. So it's not just to reassure board and the public, it's not the management of sepsis that is proven to be the problem, it's the screening compliance and the data collection around that we're struggling with. But yes, I think every time we have a further meeting, Tony, something else comes up. But every time we find more information, we are one step closer to getting the solution in my book. And I said, we've got the clinical leads and the digital leads now very well linked up and working on this together. So hopefully we should be able to get to a point where our data capture for this area is much more transparent.
Thank you, Jules. We look forward. Progress is progress. Just like it to be a bit faster, please. Okay, we'll move on then to workforce. And Ali, over to you.
Thank you, Chair. So this month in the pack, you'll note that there's been some funded establishment growth noted, particularly within urgent and emergency care, but also into paediatrics as well, because of a successful business case there. Our vacancy turnover levels remain in a good place, particularly low vacancy levels should be noted across nursing and midwifery as well. And we're starting to see some good progress against some of our consultant vacancies, in areas that may have been traditionally hard to fill as well. I think, as Glenn alluded to earlier, as he was talking about the annual planning process, for our workforce planning this year, and in line with that national guidance, we'll really be focusing on making sure that we don't grow our headcount, particularly across corporate and infrastructure areas, and making sure that we maximise that opportunity through natural turnover, but also through transformation and doing things differently to get the most value for money in that area, but ultimately reducing that headcount through that natural turnover and transformation opportunities, and being very clear when vacancies arise whether we need to recruit to vacancies in a like-for-like way as well. Continued priority for us is really going to be that reduction of agency staff. We clearly don't want to be as reliant on agency staff as we are at the moment, but note that much of that use is around our emergency care pathways as well, and some of that system pressure around escalation in that area can make it quite difficult to come out of that dependent state with agency workforce. That said, what the pack does detail there is real progress in the last year in terms of moving away from off-framework agency usage. And what that means is that we'll have more assurance that when we do use agencies and they've come through a framework procurement route, that those quality checks are in place with the agency around the quality of those workers as well, and that the prices come under that framework control. So whilst we still don't want to be using agency, if we do need to use agency, there's more assurance if they come through a framework route as well. I think, as Stephen alluded to earlier as well, sickness remains a challenge for us. We are very conscious that there's a lot of pressure on our workforce for all of the reasons we've talked about so far today. And that, you know, in conjunction with their busy lives and other pressures, we are seeing high rates of stress and anxiety continue as a reason for absence. And whilst we have a good wellbeing package, we know that, you know, individuals continue to need considerable support to stay well at work and also recover and get back to work as well when they have been poorly. I note as well in the pack, just to draw to your attention, continued pressure around job planning. We are seeing some improvements in some areas, and the CMO office have been working hard with divisions to resolve some of those outstanding historical job planning queries and concerns as well. So we are confident that will continue to improve. But it's worth noting that NHS England have imposed a 95% target for compliance on trusts. So we are some way away from that at the moment and still need to continue to work hard to be able to achieve that. And probably to finish my summary on a positive is just really to highlight the outstanding continued performance around statutory mandatory training. It's really important for our colleagues that people stay up to date and safe with that training. We consistently hit or achieve above that target. We have recently signed up to a national memorandum of understanding, which will allow for some statutory mandatory training to be ported for those NHS workers that are moving trust to trust, so they don't have to redo the same training within a short time frame. And that will only help us to continue to achieve great results in that area. So, you know, thank you to all of our colleagues for applying the diligence necessary in that area as well.
Great summary, thank you, Ali. Collins asked the question, given the increase in establishment through business cases, how are we monitoring the benefit realisation? Is that the question really for Neil to answer rather than you?
Happy to do it in tandem with Neil, yeah.
Okay, so you go first, Ali.
So in fact, Neil and I were only talking about this last week and just making sure that through our strategy and planning that we actually do come back and monitor those benefits. I think the key is understanding when those business cases are approved, being really articulate about what the benefits are and how they'll be realised as well. And we are scrutinising that quite clearly as we go through.
Maybe through FRB we can think of a way, Stephen, of capturing those reviews of the business cases. Little conscious of time, colleagues. Any other questions to Ali? I did mention FRB, which is the Finance Recovery Board. For members of the public, there is a subcommittee of this board, effectively it's all the board, who meet once a month to look at our financial performance. So we do spend an awful lot of time on finance. And so, Neil, what would you like to pull out of your report, please, for members of the public?
Yeah, thank you, Chair. So positive news again from a financial perspective at this point in the year. We've seen another improvement in the month, £500,000, that brings us back to our year-to-date plan position of 4.9 million deficit. So progressing well as we head into the final month of the year. Driven by increases in interest associated with our bank balances and some PFI technical issues. From an elective income perspective, we're still progressing well. We're still working on the basis of the fact that we will get paid for work above the cap that's been identified. And our ICB is very supportive in that respect. From an expenditure perspective, pay and non-pay, very much driven by the additional activity that you'd expect over the winter period. And the real acid test for us now, as Ali said, is really how we're going to de-escalate those as fast as we possibly can to improve our run rate into April. We're seeing increases in drugs costs, and again, through our ICB contracting, we just need to be a little cuter this year in terms of making sure that we've got all of that covered contractually, so that the risk isn't entirely passed on to us. So at this point in the year, we're still projecting confident that we'll achieve our financial plan, and we're working towards an upside. The extent of that upside very much driven by a number of risks that we're managing at this point in the year. Income risk that we're working through with our ICB in particular. I should just say as well, in respect of our CPIP, seeing fantastic achievement at this point in the year in respect of our CPIP, probably the largest CPIP that we've delivered, certainly in my time at this organisation. So positive credit to all those involved in developing that programme of work and delivering it throughout the year. In terms of capital, just wanted to pull out capital because we're still showing at month 10 anyway, significant underspend towards our year-end projection. Pleased to say that we placed significant number of orders in month 11, and I'll know the outcome of month 11 in a matter of a day or two. Still working with the workstream leads on a week-by-week basis, and I've got assurance from them that we're still on track to deliver the plan in its entirety. So positive news there. Happy to take any questions, Chair.
Thank you, Neil. And just to reiterate your point on the cost and productivity improvement plans, which I think have been quite exceptional. And thank you to all of the leadership teams in the divisions who have delivered that. Any questions or perspectives to Neil? I think we're all pretty briefed after the FRBs and the various different processes we run through. let's try and create that little bit of upside for the system. And we power into next year, I think, in a stronger position than probably we've been in the last 10 years. So fingers crossed for the year ahead, despite the difficult challenges that Glenn has already indicated to us. Okay, team, so we'll move on then to the perinatal safety report. As I said, bringing life safely into the world is one of our absolute top priorities. Justine, over to you.
Thank you, Chair. So this safety report for January, I haven't got a huge amount to say this month because not an awful lot has changed over the last couple of months. However, just a couple of things to highlight. We've seen that slight fluctuation around bookings by 12+6 again, which is disappointing because we're trying to aim for the stretch target now of 10 weeks, but our self-referral is really making a difference there as we expected. I'm not going to talk too much about sickness because I'll cover that in the staffing report, although I must highlight that in this report you'll see that neonatal nursing didn't meet BAPM standards in January, and that was a combination of that high sickness but also high acuity. They were really, really busy. Training you'll see is on track. As Ali's already talked about, mandatory training does remain challenging for some of our groups, particularly that rotational medical staff group. So to passport in existing training will really help us there. The crude perinatal mortality rate remains below the national average, but sadly we did report 2 stillbirths in month, and I'll talk about those in detail in the private session. You'll see that our induction delays are on a downward trend, but there's still further work to do. And unfortunately, we saw a slightly declined position in our heat map this month based on a data quality issue around ethnicity, but also a stakeholder concern that was raised from our ODN colleagues. We are querying that, and I'm waiting to hear that that's going to be removed because it was actually a delay and an error. So hopefully that will look much better next month. Glenn has signed off the MIS declaration form, and we're declaring 9 out of 10 against CNST with some additional evidence submitted in the hopes that we will actually achieve the full 10 out of 10 incentive. So we'll be able to, as soon as I know, I will let you know, but keep everything crossed. Happy to take any questions.
Thank you, Justine. Just an observation from me. I mean, at 8% sickness level, that's sort of 20 days almost sickness every year on average for members of staff, which is a mighty big level of sickness absence. Questions or perspectives to Justine on the perinatal report, Glenn?
Just an observation, no need to comment on this. I mean, it's obviously in the context of the financial challenges that the NHS faces. I think increasingly across the group we'll be looking more at the outcomes rather than the inputs. So I think things like Birth Rate Plus tool, things like safe staffing guidance, I think they're less important than our actual outcomes. So I think that's something we just need to keep an eye on. And Secretary of State for Health is saying that we should be focusing more on our local outcomes and less on those input measures.
Duly noted. Thank you, Glenn. Any other questions to Justine? Going to be some interesting discussions about that as it develops. So we'll move on to the safe staffing report. And Justine, back with you.
Indeed. So the safe staffing report for January, you'll see that we were safe on all shifts. As we've talked about, the sickness has increased in both groups, and it kind of reflects the seasonal variation again of last year and the year before. So we do hope to see that come down once we get out of this cough, cold and flu season, which was the reason for most absence in the last couple of months. You'll see that vacancies have continued to drop, and we've now got a 5% vacancy rate in our midwifery team, which is really good news. We've got a further 12 whole-time equivalents who we expect to onboard across March and April, which will give us as close to a 0 vacancy position as we have ever been in. We also have a waiting list of staff who want to come and work with us, and staff who within the team already want to increase their hours. A bit of an enviable position. I didn't think I'd ever be able to have this conversation. So a good time ahead. The time acuity was met, you'll see, is improved, and that obviously helps with the health and well-being of staff, because we don't need to move staff around the service to make some of our more acute areas safer. And we didn't have to rely on our continuity and community colleagues as much as we have done in the past. So again, that will improve their health and well-being. You'll see there that all incidents reported, there was no harm, and that's the report for January. Take any questions. Thank you.
No, super. Do you mind if I run into Sarah on nursing, then we come back to both? So Sarah, over to you on nursing, safe staffing.
Yeah, thank you. So I'm pleased to say that staffing on paediatrics, neonate and adult inpatient areas maintains safe staffing levels throughout January. And that's despite the high turnover of patients and the fluctuating acuity levels on Riverbank and in the paediatric A&E with RSV cases. I've already talked about the additional areas that have been opened to manage the pressures in the ED department, but just to note that all of those additional areas that have been opened remain open today. I'm pleased to say that there were just 25 insignificant or minor incidents reported associated with staffing. And just to draw the board's attention to our current vacancy position for our registered nurses currently sits at 1%. And that is a total of 23.65 whole-time equivalents, which is fantastic. And just looking against the model hospital data, that stands at 8.1%. And we're also improving month on month on our healthcare support worker vacancies, which currently sit at 7%. Our banking agency usage throughout December was 562.4 whole-time equivalent totals, and this included the additional areas that we have open for winter pressures. And Ali has already touched on the rise in sickness, but we have had an increase at both RN, registered nurse and healthcare support worker sickness, but just to bear in mind that we were dealing with flu, COVID and norovirus, of which our staff are susceptible to, along with patients. So I will stop there and happy to take questions.
Thank you, Sarah. And a question Michelle's asked in the chat box about, and lots of positives in the chat box about recruitment for both you and Justine. But Michelle asking about the implementation plans to improve employee satisfaction. I think when we see the staff survey results, which we can't talk about at the moment, we'll be quite pleased with the way employee satisfaction is improving, although we've still got a long way to go. So Michelle, with your forbearance, can I ask us to hold that question until we've got the staff survey results, because I think we'll work in a better context. Otherwise, we won't be able to talk about some of the things we want to talk about. Karen?
Thank you, Chair. Just picking up Sarah or whoever about the fact that we don't cover maternity leave or sickness in terms of an uplift. I knew about maternity leave. We've discussed that before. I have to confess I hadn't quite realised or remembered about sickness. So does that mean that when we're talking about additional bank costs, presumably not agency, I don't know, might be agency on some cases, I guess, are we showing that separately? Because clearly there'll be areas where we have no choice other than to cover.
Yeah, so there is a more detailed breakdown, Karen, that goes through Nursing Midwifery Advisory Group on the reasons for the use of agency or bank, and we will always try our best to cover with bank first. And there's a number of processes we go through before we would put out to agency.
And I'd understood, correct me if I'm wrong, but I'd understood that we were looking at potentially including some headroom for particularly sickness, I would say, but also maternity leave. Is that not the case, or have I misremembered that? Or
no, you haven't misremembered that, Karen. So the paper on maternity leave is just being finalised now, and I'm hopeful that we will be able to look at that kind of middle of March time. The sickness conversation around baseline budgets, that's a conversation that me and Neil will pick up in our one-to-one this week. It's conversations that we have had, but I think we just now need to reach a decision.
Thank you.
Okay, and Justine, then we'll move on.
Yeah, just to say, Karen, because of previous history and being aligned to Birth Rate Plus, we do have a headroom for sickness absence at 4%.
Okay. Thank you very much. So we'll move on then to the Patient and Public Forum report, and delighted that Rosemary Smart's joining us. Rosemary, 5 minutes will probably be a little bit short, but you're more than welcome to take 10 minutes or as long as you like to update us on the very important work that our Patient Forum do for us. So Rosemary, unless you want to do an introduction, Sarah.
I think this just to say, Russell, that this is our first Patient Public Forum report, and there will be 2 reports a year to the board. It's really important that we hear the patient voice directly at the board, and this is us demonstrating our move towards doing that. So I'll hand over to Rosemary.
Thank you, Rosemary. Welcome.
Thank you very much, and I really appreciate being invited to speak to you all today. The Patient and Public Forum considers themselves as a critical friend of the Trust, listening carefully to the experiences, not only our patients, but also our staff, because we think it's extremely important to listen to both sides. Now, the way we do our work is by using all our senses when we visit the Trust premises. We also do it in a variety of different ways by sitting on committees, and we're so grateful to Sarah for having increased the number of committees that we can be represented on, and we really appreciate that. We also help with the ward accreditation programme and the safety walkabout programme as well. And in addition, we do many audits. The particular ones we're doing at the moment are the hygiene audit and the care in the corridor ED. It's very inspiring actually to see the improvement that's happened in ED. Still there are patients in the corridor and still it is not ideal, but I was only there the other day and every patient told me how kind and good the staff were. And the other thing I noticed as I went into the majors department, they have a plaque on the wall and saying all the attributes they expect of their staff. And I think that is really lovely. And the important one, I think, is remember to smile. Don't ignore the poor patients who are on sitting on the trolley, because it's so easy to walk past and not just acknowledge that they're there. So that's absolutely fantastic. I'd like to mention 3 things that we're really proud of. One is that we instigated the hearing loop at the CoLab at Kidderminster. And the other is also at Kidderminster, the yellow line on the floor from reception to the ophthalmology department for our visually impaired patients. I think we forget that both for deafness and sight loss, there is a full spectrum. So just concentrating on BSL or Braille, you miss out a big section. And we've had 2 members who have really helped in both helping deaf people and helping the visually impaired. The other thing that we are proud of is that we did a survey of looking at the response to complaints, the Trust response. And we had a really good meeting with the complaints team and Alan Bailey, looking at what we had found. And I think that is going to be worked into the new complaints policy, and we very much look forward to collaborating with the complaints team on that. Also for the future, we are very fixed on outpatients and the outpatient transformation programme, and we very much wish to work with the Trust on that going forward. Our main risk, though, is that we are only got 11 active members at the moment, and we could do so much more if we had more members. Sarah has very kindly offered for us to have a stall in the atrium of both Worcester and the Alex to recruit members. And if any of you know of any people who you think would be good to join us, please send them our way. Finally, I'd like to say thank you very much to Sarah, to Russell, and to Anna, our patient experience manager, for all their help and support through the last year. And I'm very happy to take questions.
Thank you, Rosemary. And I am in awe of all of my patient forums across the foundation group in terms of the genuineness, the commitment to improvement, the willingness to give up their time, and the very insightful reviews that often are always undertaken, which help us improve. So thank you, Rosemary. Any questions or perspectives to Rosemary? Hopefully, Rosemary, the idea of updating us a couple of times a year isn't too much of a problem, but I think it is a very helpful voice for members of the public to hear in this forum. You and I talk about once every 4 to 6 weeks anyway, but to reassure them about the work that's going on in the Trust. So thank you. Okay, team, we'll move on then to the board committees. And the Quality Governance Committee, thank you for your report, Julie. Anything you'd like to add?
I would just like to say that Rosemary is a member of this committee and her insights are invaluable. She is a fantastic member of the committee and I'd like to publicly thank her for that. Because of the timing of meetings, we've had a couple more meetings since then, and I'm pleased to say that most things have progressed. The things where we're having issues, Sarah and Jules have both raised today, so I won't say any more about it today.
Okay, thank you very much, Julie, and thank you for your stewardship of that meeting. Any questions or perspectives to Julie on the Quality Governance Committee report? Okay, well then we'll move on to the Audit and Assurance Committee. Colin, what would you like to pull out?
Thank you, Chair. We've had one further meeting in January of the Audit and Assurance Committee. There's nothing I particularly want to highlight from that, though, with the exception of perhaps the consultant job planning item, which we considered. It's already been touched on today, and I just wanted to flag at this point that we were concerned about some of the issues that are emerging from that. Seems to be one of those situations where the more work that's done, the more issues that need to be resolved emerge, but we're keeping a watching brief on that. That's all I wanted to say. Thank you.
Thank you very much, Colin. Any questions from colleagues to the Audit and Assurance Committee? How assured are you feeling, Colin?
On that topic, Russell, I'm feeling assured. The committee have had the opportunity to look at detailed action plans, and it's very clear it's been taken very seriously by the executive. So it's one of those wicked problems, but we are making progress, I'm assured.
Okay, thank you very much. Stephen?
Yeah, just really briefly, I think around job planning, it's one of those long-standing issues in the Trust that we're kind of working our way through. And as often with these things, you seem to unearth more, then you've really got to the bottom of it, and then you can really kind of very quickly get on a better path with it. So I think it's fair to say, Colin, that's where we feel we're at with it.
Okay, super, thank you. And we'll move on then to People and Culture Committee. Karen, what would you like to pull out of your report?
Thank you, Chair. The only thing to highlight from the January one is really, or December, sorry, how pleased we were with the work on the culture issues in the theatres at Alex. That's been a long ongoing piece of work, but we are now starting to see improvements there, so that was really, really positive. Like the other chairs, we have held a further meeting since then, which took place on the 4th of February. Obviously those minutes will come through, but just one thing to highlight here from that meeting, we took a report from the Disability Staff Network, which highlighted some of the additional work and gaps that we've got around the areas of adjustments for staff. So we've got some staff who are continuing to work or in a few cases still off work whilst we are working through the adjustments that are needed. So I think everybody's aware of that, cited on that, and the focus that needs to be placed. So we'll keep an eye on that.
Super. Thank you very much, Karen. Any questions or perspectives to Karen? I would like just to give a shout out to all of our networks, but in particular, Rena Rain and Beck Harris for the work they do with our BAME and LGBTQ+ networks. We are very, very lucky to have them chairing and leading those networks. And our focus as a board and as an organisation on the belief that being inclusive and taking all of the talents we can get into our organisation is absolutely a foundation stone for what we stand for. So thank you, Rena and Beck and everyone involved in those networks. We'll move on then to the board assurance framework and high risk update. Gwenny, what would you care to pull out?
Thank you. As I've said in the report, this is an interim report as we're developing the format of the board assurance framework, which will include a bit more detail and be in a slightly more digestible format. So I've transferred into just this report the high level risks that are currently on there, which you will see the issues within there are covered by both the board and the committees that report into it. We've also got the high risks there, which are looked at in detail by the Executive Risk Management Committee, as well as in the divisions that report into them, and some of those subcommittees as well that cover those risks. And Sarah and I are working on some developments to that particular committee, so it focuses more broadly on assurances and actions and some more detailed reports from those subcommittees. So we'll see some of that coming through from next month.
Thank you very much. Are there any high risks that we don't think are picked up on the high risk update and board assurance framework? Stephen?
Yeah, so there'll be a risk that'll be on there from next month around work that we're doing with Hereford and Worcestershire Fire and Rescue Service, around capital works that we're doing around the Alexandra Hospital. There's two main focuses that we've got, and we've got two enforcement notices that they'll be in the public domain that we're working through. So one is a robust capital plan that will go over a period of time to make sure, in particular, the hospital street is up to standard, and the second is just to make sure that our policies, risk assessment strategies, those short-term things are again in place. But just to emphasise, working really closely with Hereford and Worcester Fire and Rescue Service, we've got big capital allocation to spend around that area, and there's been a lot of work with the staff around it and the response to things. So that will go on to the board from next month.
Okay, thanks, Stephen. I don't think we're alone in facing some of those challenges with other public institutions, but Emma is certainly doing a great job for us, and the board are kept fully briefed on that for members of the public to be aware. Any other questions to Gwenny? Okay, thank you, Gwenny. So we'll move on then to the date of the next meeting is the end of March, 31st of March. But before I go to questions from members of the public, any other business, board colleagues? And any questions from members of the public? I'm not aware, Gwenny, whether we've had any, or Joe.
There was one question, actually. You may remember that at the Foundation Group board meeting, there was a question that Stephen answered in relation to potential for using some of the council car park for trust staff car park, and the person who asked that question has asked for it to be asked again to see if there's any progress there.
Okay, so Stephen, this is a long-standing issue. How are you doing?
Actually, we're doing well. So we have a park and ride option, but we are engaging with the council around conversations around County Hall in particular. So we could potentially have two options on the table, and we'll keep people updated on them. But Emma is progressing that at pace, and the council are being really helpful around that. So hopefully we'll have some announcements soon.
Okay, great. And for my sins, I must admit, I have parked in the county council car park and walked across to the hospital. So I apologise in advance if anyone else is copying me in that regard, and appreciate greatly the support of the council in allowing the occasional person like me to do so. Any other questions from members of the public who might be with us? Okay, well, again, I can't thank enough our frontline teams and the executive team for the hard work that's going on to drive forward the improvements of Worcestershire Acute. I have to say that when I joined the board some 14 months ago, I did not expect us to be making the amount of progress we have made. So I am absolutely delighted, but equally, I'm very clear that if you are waiting for a UEC in our UEC, or you're in a boarding situation, that the experience is still not as good as it should be. And if you're a member of staff waiting to get out of our site because of the car parking challenge that we've just talked about, again, I'm very conscious we're not delivering what we need to for you. So as a board, we are certainly relentless and a desire to improve the experience for our staff and the experience for our citizens. Take care, everyone. I look forward to seeing my board colleagues in the confidential board in 5 minutes. For members of the public, we will see you at the end of March. Take care. Bye-bye.